Good afternoon, everyone. Thank you so much for joining us for the second session of Family Council's Ontario 2025 Innovation Summit. This year, the format is a little bit different. We are hosting four different webinars all week from 12 to 1 p.m. And this is the second session titled Personality Disorder in Older Adults, Understanding the Person, Building Skillful Approaches, and Fostering Wellness in Care Teams, co-hosted by Behavioural Supports Ontario. My name is Taeyang Zhang, and I am the Bilingual Events Manager at Family Councils Ontario. Before we start, I would like to take a moment to recognize the land on which we are gathered today. I am currently in Toronto, which is seated on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nation, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Before I turn things over to our guest speakers, I want to share a few logistics and housekeeping rules. So, as you may have noticed, everybody is in listen-only mode right now. We have reserved time at the end for an interactive question and answer period. And I encourage you to use the Q&A box to ask your questions to our speakers. And you can also use the Q&A box all throughout the presentation to put your questions on there, and we will get to them at the end. And if you're more comfortable asking a question by audio, you can simply raise your hand and I will give you the feature to open your audio. So that's also an option. And you'll see I have my colleague Yoan with us today, putting stuff in the chat. So you are more than welcome to use the chat to share comments, opinions, reactions, or if you have any technical questions for me or Family Councils Ontario, you can use the chat box for that as well. And as you may have noticed, this webinar is being recorded, so it will be available on Family Council's Ontario YouTube channel probably next week or the week after, so you can view it and share it with anybody who will be interested or who weren't able to be present today. So now it is my pleasure to introduce today's guest speakers. Debbie Hewitt Colborne is an advanced practice nurse with experience and expertise working with older adults within long-term care, the community, and hospital settings. Her current work at the Behavioural Supports Ontario Provincial Coordinating Office focuses on activities that support the implementation of person, family, and relationship-centered care of older adults with or at risk of responsive behavioral personal expressions associated with dementia, mental health, substance use, and or other neurological conditions. And we also have Kelly Davis, who is a registered nurse with over 25 years experience, granting her knowledge, skill, and appreciation in a variety of areas, including adult mental health, geriatric psychiatry, leadership, community, and long-term care. Currently, Kelly's area of specialty focuses on mental health and dementia care. Within this role, her time is dedicated to supporting long-term care homes, acute care, community partners, caregivers, families, and healthcare professionals in identifying care needs of the older adults, determining goals of care, exploring available resources, and fulfilling opportunities for education and training. Kelly and Debbie, the floor is now yours.
Wonderful. Thank you so much for that very warm introduction. I'll just share my screen. And I'll just make sure that everyone is seeing the PowerPoint. Yes, okay, wonderful. Yeah, so thank you so much for that warm introduction. And Kelly and I are really pleased to be with you all today and appreciate that people are noting in the chat pod as well where you're from. And we know we have those that are family care partners here, as well as professionals that are working within long-term care. So a warm welcome to all of you. And we're really pleased to be able to share with you a capacity building package or some training educational materials that we've been able to create through BSO, and we're going to share those with you today. And it is important, if you're a family care partner, just to also know what the team members within the long-term care home are being trained. So although the training itself is geared towards team members, we definitely think that it's important for you to know what is part of that education, and really pleased that you're here to join us today. So many of you may know what Behavioural Supports Ontario is or have heard of it, but we just thought we'd start with what it is. So it really is services that are provided to older adults within Ontario that have or are at risk of having responsive behaviours or personal expressions. They can be called different things, but they mean the same. So responsive behaviours that are associated with dementia, complex mental health, substance use, or other neurological conditions. And we have teams across the province that do that. And they also provide support to family care partners and also healthcare providers across sectors. So we predominantly do work in long-term care, but we also work in the community and in acute care. And I work, as was noted, in the Provincial Coordinating Office. So we have a few people provincially. I'm in North Bay, and we provide support and leadership across Ontario to the teams and the leadership. So one of the things we do at a provincial level is we bring people together that have common passion on things and common work that they want to do together. And we have a community of practice, or that kind of group of people, that is called the Knowledge to Practice community of practice. And that group is really educating educators and clinicians who share that common passion for capacity building and knowledgeable care teams for those that are providing care for the BSO population. So again, older adults who have responsive behaviors associated with dementia, mental health, and other neurological conditions or substance use as well. So we meet 5 times a year, but we do projects together as well. And that group of educators, and Kelly is one of them as a PRC, and there are many other, so PRC psychogeriatric resource consultants and many others across the province. They started to see an increase in requests from care teams around providing care to older adults with mental health conditions. This especially was happening in long-term care and continues to happen. And so they thought that they could work together as educators with the support of the Provincial Coordinating Office of BSO to build capacity building products or education products that they would use themselves and others could use, kind of grab and go educational resources. So that was our goal, was to have grab and go evidence informed resources to build capacity in all sectors. So including long-term care, for those clinical teams to skillfully and confidently care for individuals with mental illness. And our first prioritized mental illness was personality disorder. And so it was specifically our first one. Our goal was around confidently caring and skillfully caring for those with personality disorder, and to avoid compassion fatigue, because that often can happen with care teams that are caring for someone with personality disorder. And we'll get into that a little more in our presentation. So we had a goal to build those education products. So we first had a working group that we established. We also have a knowledge to practice framework. So thought of our project in that framework, wanting to create tools that would be understood and help people to apply them in their everyday practice. Our target learners of the education, it was those point of care team members and leaders in all settings. But what that would mean in long-term care would be the PSWs, the nurses, dietary aides, the directors of care, administrators, and such. And then who would use the products themselves would be educators to be able to bring that to those learners. So we also, as a working group, defined some themes that were really important that we wanted to make sure the education materials spoke to, which was understanding personality disorder, essential care and communication strategies, assessment and care planning, and individual and team wellness. So we gathered literature and existing resources. We also commissioned an artist to help us build a fictional person who's living with personality disorder. And you'll see him sitting in the chair and you'll get to know him a little bit over the next hour. His name is Randy. And we really wanted a personalized story to be able to elicit empathy throughout the learning process. And then we built the capacity building package itself. This is a glimpse of it, and it's available on our website. There's a QR code if you'd like to scan or use your camera to find the QR code and website. And I think it's also going to be popped in the chat for you. But really, there's a background and guidelines document for the educator themselves. The information booklet is mostly for the educator as well. It's over, I think, 35 pages. It's in-depth information along with the story of Randy. But it's really to help the educator themselves ensure that they feel knowledgeable and confident around personality disorder. And then there's two slide decks, a brief 15-minute one and more of an hour-long slide deck. It has speaking notes for the educator, but if they get a request for education, it depends how much time they're allotted, they could take either of those. And then there's also 5 tip sheets that are 1 or 2 pages long that they also can print and take. So when they do the education, they can provide it to those learning as well, just to be able to take some key points with them. Briefly, I just wanted to tell you a little bit about what we've heard from those that have completed it or been introduced to this information. So we have a survey that's through a QR code on all the education materials. So anyone who has presentation by the slide deck, or if they've looked at the fact sheets, they can fill it out. And you can see the green and blue really show that people feel that their confidence for caring with personality disorder has been improved or much improved through the resources. And also just we asked for a bit of a star rating around overall, how would they rate the resources, and there we're at the 5.0. It is just a small sample. You'll see it's just 29 that have actually completed the survey to date, and we look forward to hearing from people a little more. We also just wanted to let you know the survey also asks how the person is going to apply the learnings to their practice. We definitely want to know about application to practice, and in terms of caring for someone with a personality disorder, they learned that and wanted to apply that you have to collaboratively build a care plan, consistently follow the plan, set healthy boundaries, and follow through to build trust. And then we also asked them about strategies that they were going to put in place to promote their own wellness. They talked about self-care and just appreciating that sometimes care situations are difficult, and they need to prioritize self-care inside and outside of work as well, to work as a team and communicate well, and to establish healthy boundaries and maintain them. And later, Kelly's going to talk about that importance of healthy boundaries in regards to personality disorder. I won't read all of these, but a few quotes from our educators. Following Randy as a person with a story throughout the resource humanizes the information. Learners are very receptive to this approach. And another one, I found the package very easy to use and the speaking notes detailed enough to facilitate and generate discussion with participants. I found the use of Randy as a case example to be realistic, a realistic representation of a person that long-term care members could relate to, and often saw participants nodding in agreement and with the scenarios presented. So that's a little bit about the resource itself, an overview and what we've learned. But Kelly's going to walk you through a little bit more. I'll let her speak to it, but as if you were yourself receiving the education as well, because we thought you might want to learn about personality disorder too. So I'll hand things to Kelly.
Thank you, Debbie. Good afternoon, everybody. I gather we can go to the next slide. So I'm just going to talk a little bit about personality disorder and what is it? So when we think about what personality disorder is and how it affects the person, it is a mental health condition where a person's thoughts, feelings, and behaviors deviate significantly from what would be normally expected socially and culturally. So personality disorders, they do reflect long-term learned patterns of behavior and functioning that affect at least two of the following areas. So we see it can affect a way of thinking about oneself. So they could have very negative thoughts about themselves. They could have low self-esteem. They could really struggle in empathizing with other people, the way of responding emotionally. So a lot of times we may see these emotional outbursts from people where they just get very upset or they feel as though something has complete catastrophe or they um, catastrophize things when to the average person and maybe something that's seen as quite small and not seen as a big deal. Way of relating to other people. So you may find and see people with personality disorders, they often struggle to maintain healthy relationships. Quite often, the relationships are estranged, which makes it very, very difficult to get information, solid understanding about the person, their history, and those learned patterns of behavior. It can be quite difficult to obtain information regarding that because there aren't a lot of people that are able to um, collaborate on the person's behalf or with the person. And also a way of controlling one's behavior. So when we think about personality disorder and we think of two of those areas that are being affected, it can have a significant impact not only on the person, but everyone around them. So as a result, people living with personality disorder, as I already mentioned, they often struggle to maintain those healthy relationships because of those interactions and the patterns around the types of interactions that they have had or continue to have. They create a lot of tension. So when we think about personality disorders, there's actually 10 different types of personality disorders that are grouped into three main clusters, which are A, B, and C. And I'm not going to go into too much detail about the different types of personality disorders. That information can be found, as Debbie mentioned, within the education package, specifically the information booklet that's available on the Brain Exchange website. So thinking about the development of a personality disorder, so it is a result from a complex interplay of genetics, environmental, and learned factors. So quite often, the traits of a personality disorder, they stem from strategies that were self-protective in nature. They were developed early on in the person's life as a result of adversity, trauma, and or neglect. So they were formed when there wasn't an attachment figure to trust or consistently rely upon. And it really resulted from a lack of those positive role models and healthy relationships. So quite often, personality disorders develop as a result of life trauma, as mentioned. So it could be verbal abuse, any type of trauma, sexual abuse, physical abuse, neglect, or psychological abuse. Go to the next slide. So as to be mentioned, we really chose to depict a person, a real live person that's carried throughout the personality disorder package. And it was really to help people relate to a person. And not only that, but to use that trauma-informed care approach. So a little bit about Randy, talking about, he's a fairly young male individual. He was only 62 years old in our story, really tapping into Randy's personhood, but also to help people understand, some of the struggles and challenges a person can be faced with when moving into a long-term care home. So thinking about Randy, he lived on his own, he didn't have a big family, he kept to himself, all of which are going to pose some significant challenges and struggles when moving into a long-term care home when we think about that change and we think about how change is difficult for anybody. But when we have our own way of doing things and then we come into a very, very structured environment, so thinking about new food. And quite often, meals are a significant um, highlight, if you will, in a long-term care home. We place a lot of emphasis on meal times. So, are the meals, um, the food that's being served, is this what would have been part of the person's routine? Even the times that the food is being served, or even just eating in a dining room with a lot of other people, could be a big, big struggle and challenge for an individual with a personality disorder. New routines, if somebody's used to sleeping until noon, and now they're being expected, or the expectation is that they wake up early and they're joining other people. The social demands, just living with a lot of other people. Meaningful activities may not be accessible. So, what may be of interest to the individual is just not available within a long term care home setting. Um, in Randy's case, he had suffered from other physical ailments. And as you can see in the picture before you, he is dependent upon a wheelchair. So having to rely on others now for certain care needs, which could include bathing. We already talked about the new people, loss of independence, loud environment. There's a lot going on, a lot of comings and goings in and out. Um, and so thinking about those things and the impact that it would have on the individual when moving into a long-term care home. Also looking at communication strategies in terms of meeting those essential care needs of the individual. So really wanting to promote regular team communication. And that's really difficult because consistency and that continuity of care is really what is going to benefit the person the most when moving into a long-term care home environment. Offering opportunities for positive interactions and healthy engagements to promote healthy coping mechanisms and strategies. So we really want to model those healthy relationships for the person, because that's what has been absent throughout the majority of their journey throughout life. And so as the care provider, as a team member, modeling those healthy relationships, modeling those positive interactions with the individual. So sometimes when we're confronted with negative behavior, it becomes almost easier to focus on the negative behavior, but just being mindful of the fact that we still want to really, really promote those healthy interactions, and when things are going well, and reflect that back upon the individual. Establishing rapport, maintaining professional boundaries. So quite often, the person may seek out some personal information from team members, from care providers, and it's really essential to maintain those professional boundaries that reaffirm, who you are, what your role is, and what you're there to do. You're there to support the individual, but you're not necessarily there to become their friend. Ensuring that team-wide consistency. And so this is where we really talk about involving all team members. So irregardless of your role or your department, it really is essential to have that open communication with all departments, get everybody involved, as well as the individual. So keeping them informed of any changes, including the individual in their care plan and in creating that care plan, and maintaining the consistency around the care plan, because quite often, as you'll see, I'll speak to it in a few minutes, the person is really going to test those limits and test those boundaries. And before you know it, we're changing things all the time and nobody can keep up with those changes. So being consistent and continuous around our approach. Addressing any medical emergencies, including self-harm and suicidal ideation. It would not be uncommon for a person living with a personality disorder to voice suicidal ideation. So taking those expressions seriously as a team. We can go to the next slide. And again, I just want to make mention on the bottom of the slides, you will see the previous slides, you'll see that the information is available in the tip sheets. Thank you, Debbie. Yeah, so just at the bottom, there are those 5 tip sheets that are available within that information package for more information on those things. So in terms of Randy's response and what we can anticipate from an individual when they move into a long-term care home setting, I already touched upon this. A person can test those limits, test those boundaries. And it can be very difficult for them to sort of fall into, that expected structure or routine that falls very much outside of the person's routine. And when we talk about Randy and we think about some of the things that he was interested in, and how it may not be a fit within the new environment, it can be very difficult for that individual, and it wouldn't be uncommon for them to then have a negative response. And so, really, reflecting upon the fact that we can't change the individual, really what we do have control over in that moment is how we choose to react or respond. And it's okay to set those limits, validate the person's upset or anger, but also being able to take a step back, and recognizing that, what, they probably just need a moment. I'm going to take a step back and reapproach in a little while. So yes, the person can become upset, but recognizing that we're not there to get into a battle for control. We don't have control over the individual. We don't want to get into a power struggle. So recognizing that it's okay to take that step, pause, and come back to the person at a later time. We also, talk about how the personhood of the individual is extremely imperative and key in terms of that care planning piece. So we still want to look at that comprehensive behavioral assessment, thinking about things like whether or not there are any contributing factors. So physically, could there be something going on with the individual? We still want to take into consideration account things like pain, documenting the behaviors in detail. So one of the things that we recommend is that ABC charting can be really helpful when we're trying to have consistency and that open dialogue, talking about, some of those assessments, some of the antecedents. So what happened before the behavior, being very descriptive around the behavior, the person's personal expression, and then, what was the outcome or the consequences of that action. Identifying some of the behavioral patterns. So there are different tools available, such as the Behavioral Support Observation Dementia Observation System from BSO that can be really helpful in tracking and identifying different patterns for the behavior. So, sometimes it feels as though a person's responding the way they are for no reason, or maybe it's happening all the time every day. And it isn't until we draw upon something like the Behavioural Supports Ontario Dementia Observation System that really breaks things down and takes that 24-hour snapshot of a person into those 30-minute increments to see, what, actually they're really upset during shift change, or they're really upset around loud noises, or every time, music is playing. So really knowing the person first and foremost, as opposed to focusing on the illness or the diagnosis itself. So in terms of Randy's assessment, we found out that his favorite drink was Coca-Cola. We found out that he was a retired crane operator. He loved motorcycles, and he often would be found when living in the community working on his motorcycle. He also loved old cars and really liked building those modeled cars. He enjoyed some snacks and the occasional treat, specifically chocolate chip cookies, and he played the guitar. So taking into consideration some of these assessment pieces and pieces of the person's personhood that really could help us develop care strategies that make sense for that person. So how do we build that into the plan of care for Randy? So offering him perhaps headphones so that he can listen to his music in private. Looking at different motorcycle magazines that could be provided to the individual. Could we offer the person modeled cars that they could work on? So, engaging them in the interests that were important to that person is also imperative in terms of the care planning piece. Go to the next slide. So when it comes to those communication strategies in difficult moments, we came up with an acronym, and the acronym is AVOID. So A is avoiding that controlling language and power struggles. So, if a person is responding in a negative way, or they're yelling, or they're cursing, in that moment, we can't change them. We can't change what it is they're saying to us. And so just recognizing that saying things such as, oh, that's inappropriate, or you can't talk to me that way, it's not going to be helpful, because before we know it, we're in this battle for control, or we're in a power struggle, and we're not going anywhere. We're not getting anywhere with that individual. So instead, we want to communicate using neutral and objective observations, making sure that we're using a calm tone, we're relaxed, we have open body language. B is accommodating various multiple requests. So reminding the person of the agreed upon limits. So the last thing we want to do is offer a solution for all these different requests. And you will find that there are going to be situations where the person, asks you, for a snack, or they ask you for a drink, or they want you to take them out. And then when you're out, they want you to make multiple stops, and it's just not feasible. It's overwhelming for the person and for the care provider. So making sure that, if they are asking us for different things, being firm about the limits. So an example of that could be, you know what, I can help you with two of those things, or I can help you with one of those things. What is the most important thing for you in this moment? O is offering too many choices. When we have too many choices available to us, it becomes overwhelming. And when we think about being something being manageable or sustainable, and we think about, particularly in a long-term care home setting or another care setting, there are different shifts with different people. So what we're offering, on one shift, could that same option or options be available on another shift? And if the answer is no, then it's not manageable and it's not sustainable. So it's not something that we can be consistent or continuous about. And so we should just really be offering what is manageable and sustainable in that moment, and then stick to the plan. I is internalizing negative criticism. It would not be uncommon for a person with a personality disorder, to pick out, a weakness of a care provider or a team member. And so it makes it feel very personal. But at the end of the day, it's not, because if it wasn't you, it could be another person. So just being mindful of the fact that, it's not about us. If something negative is being, communicated to us, just reflecting back on the positive feedback that we're receiving from others and not taking things too personally. D is developing a special bond. This is something that, care providers, staff members really struggle with, because when we are caring for individuals, regardless of their diagnosis, everybody wants to do a good job. We're in this because we care about people. We have big hearts. And so when we feel as though the person is really signaling us out as that one person, that one individual that's doing this amazing job, and nobody else can do as good a job as we can, it tends to feel really good. But recognizing that it's not just us, we are part of a team, and remembering our professional boundaries, and avoiding those personal disclosures, right? So remembering that, one individual doesn't work 24/7, 7 days a week. We are a team. And so we really want to reinforce the idea, and the concept around that team approach with the individual. And we can go next slide. So in terms of setting those healthy boundaries, it really boils down to 5 steps. And so step 1 is stop. So I already touched upon this. If you find that you're coming across a really difficult interaction with an individual living with a personality disorder, you feel, your heart is starting to beat a little bit more loudly. You feel, you're starting to get a little bit anxious. You're getting a little bit uncomfortable. In that moment, that's when you just want to take a deep breath and just stop. And think about, what is it that you have control over in this moment? Again, you can't control the person who's upset, that may be cursing, maybe talking to you in a raised tone or voice, that's making it very uncomfortable. Just taking that moment and really putting a lot of thought into what you're going to do next, or what available options do you have as next steps. The second step is assess, reflect. So again, in this moment, what do I have control over? I can't control what the person is saying to me or how they're saying it to me, but I do have control over perhaps validating, which is the third step. So, for example, I see you're upset, which not only validates, but it also puts it back on the individual. You're upset right now. 4 would be establish a healthy boundary. So, validate, you're upset right now. I'm going to come back when you're calmer. And then simply 5, the fifth step is follow through to build that trust. So you have to go back. I always recommend not giving really explicit timeframes because we know things happen. We very much live in the gray. We are caring for people, we're working with people. So even though we had the best intentions of returning within 5 minutes, it may be 10, it may be 12. And if it is right there, we haven't built trust because we haven't followed through on the agreed upon limit. So instead, using terminology around, I'll come back when you're calmer, but then going back and following through. So that can't be hours later. It would have to be in a reasonable time frame. And that's how we're going to build trust, because the more we do that and the more consistent we are, the more the person is going to learn to anticipate our response as a care provider. So in applying, the steps to setting healthy boundaries with Randy, the example that was used in this case was that Randy was continuously calling the call bell. So he was on the call bell several times per hour. And even though the team was going back and they were answering the call bell and they were trying to do everything they possibly could for Randy, it just wasn't enough, and it was never enough. And quite frankly, at the end of the day, it won't be enough because there's always going to be more requests from the individual. And so in this example, the team came up with a healthy boundary that was to respond to the call bell once in the hour. And so by following through and being consistent and having those proactive check-ins, and it really helped Randy build trust, but also anticipate that yes, the staff would be coming back. They're not just going to leave me. They're not going to abandon me. And so just a quick recap of the successful strategies that we've already discussed. So learning about personality disorder is paramount. The more that we understand, the more we know, the more opportunity we're going to have at coming up with strategies that make sense for the individual, that are person-centered, avoiding that internalizing negative criticism, because again, it really isn't about us. The person that's speaking negatively to perhaps one person, they could also speak negatively to another person. So instead, really focusing on those positive interactions and the positive feedback that we are receiving from other people, other members of the team, is really important. Using self-care strategies, it's really important to look after ourselves, because caring for an individual with a personality disorder, it can be emotionally and physically exhausting. And so whatever our coping mechanisms are, it's really important to engage in those. Ensuring that we have regular team communication. So a lot of times, I know homes that I support, they'll do team huddles. So they'll come together, they'll have those conversations, they'll do those check-ins. It doesn't have to take a long time. It could be 5-10 minutes maximum, but making sure that they are occurring regularly, because different people working, part-time, full-time staff, people go off on holidays. So making sure that we're always keeping the lines of communication open, supporting one another as a team, maintaining the professional boundaries, including the person in the care plan. So a lot of times, I will encourage teams to kind of have the conversations around what is manageable and sustainable first and foremost, to figure out what options you can actually provide to the individual. And once that has been decided as a team, then you can include the person in the care planning process by saying, what, we understand that you would like to do this, and we have this or this as an option. But then also making sure that once the care plan is developed, that we stick to it, and we stick to it for a solid time frame, because it's going to take time for the person to adjust to the care plan, to the changes. and things don't happen overnight. So I always recommend at least 3 months and doing that 3-month review, which is pretty standard in a long-term care home setting, because they do those quarterly reviews of all individuals that are living in the home. So that would be part of their policy. Setting clear and realistic expectations, already touched upon that. And that team-wide consistency in terms of those care strategies. So again, it can't just be specific to one department, really including all departments, irregardless of the role, really reinforcing and promoting that collaborative care approach. Because, in terms of testing the limits and the boundaries, a person could go to any member of the team. And if every member of the team is not aware of the plan, is not aware of the healthy boundaries that have been put in place, that's when things can get confusing and frustration stems. And then that's what leads us down the path of compassion fatigue and burnout. So something that we definitely want to avoid. And so that's it for my section. And I gather what we can do now is open it up for questions or comments that anybody may have. Thank you.
Thanks, Kelly. And I think people are able, we welcome you to write in the question and answer part of the webinar. Hey, Young, I see you back. I don't know if you have other directions as well.
Yes, so if folks could use the Q&A box to ask your questions, or as I mentioned in the beginning, if you'd like to use the audio, you can just raise your hand in the React button, and I can give you the feature for that. Debbie, if you could maybe stop sharing your screen just for this session, so we have the full screen with everybody. And yes, everyone, please feel free to use the Q&A box to ask your questions.
Yeah, thank you so much for the question. It says, how can these principles be applied if the resident has dementia? And I did want to clarify, because I don't know if people were joining throughout. And so certainly today's conversation is really that we were sharing our very specific strategies for someone who has personality disorder. We do know that in nursing homes, predominantly those that live there are living with dementia. And so the care strategies that we were speaking of today aren't the care strategies that you would use for someone with dementia. They're actually quite different and specialized care strategies. Things like setting boundaries, that's not something that you would do for someone with dementia. And there's lots of other specialized skills for that population. So that's an important question and just an important one to clarify. And I think it's also why we made the capacity building package, because those that work in long-term care, a lot of their training is to provide care for people with dementia and have quite a bit of training and expertise in that. And when they try to apply those same skills that they have with someone with dementia, with someone now coming in and living there that has who lives with personality disorder, those skills don't necessarily work with that new person, and that there's those added skills that are needed. So really, actually, as we want to personalize care for people, we would want to help the staff to be able to know how best to care for that person with dementia versus the person with personality disorder versus another resident who may have a different mental illness as well, or such, or a chronic illness, a medical issue, and don't have either dementia nor a mental health condition at all. Kelly, do you want to add to this at all?
No, you covered it, Debbie, but yes, I agree. The strategies are very different, and we would use a completely different approach for a person living with dementia. Sometimes, though, it's come up where, the staff aren't sure, the team's not sure, right? Because There's mention maybe in the chart that there's some cognitive impairment. However, the person is really presenting with some characteristics around a personality disorder. And so again, it goes back to your assessments, finding out as much as you can about the individual, even doing, things like Montreal cognitive assessment may be helpful because that's something that could really indicate, some areas of the brain that have been affected by dementia where the person may need some assistance and support. But yeah, very different strategies for sure. And again, I think the only other thing I was going to add is in a dementia, there are significant changes that are occurring within the brain, right? So brain cells are deteriorating, they're degenerating. And so it really is a different disease and really separate from a mental illness or a mental health condition such as a personality disorder, because in a personality disorder, we don't see those changes within the brain, right? The brain cells are not dying, the brain isn't atrophying. So it's just a completely separate condition altogether. Thank you.
And I see a question, do you have suggestions on how family council members and caregivers can have these difficult conversations considering the stigma around mental health? Any tips for how homes can facilitate these discussions? What a great question. And just thank you for being proactive as a family council and wanting to be able to help with the stigma that does exist around mental illness. And we do know from many of our long-term care partners, as we started the conversation today, that there are more individuals in long-term care right now that have mental illness than before. And so you're right that there can often be stigma around this. And I would just say for family councils to learn, to be curious about the diseases and to learn. You're here today because you are, and we're really grateful for that. And for example, even though we our capacity building package we made were really for educators to bring to staff themselves, but there are perhaps pieces in it that you could look at as well. And well, I think I don't have the right one. So I was just going to bring up the myths and facts. That was one. I hope that's what I'm sharing right now. But in one of our tip sheets are about myths and facts of personality disorder. So that might be something you want to learn about, or even the information book that Kelly talked about and I talked about that speaks about what personality disorder is and just learning together and having those conversations. And we want, and I'm sure all of you want long-term care to be a welcoming place that cares well for the needs of all that are there. And so I think family councils does play an important part of that, and ways to learn and grow together. And it's not always easy, and the needs of different people are very different. And in long-term care and all living in one space and sharing space, but the more we can learn and come at it with an understanding of what that person's life has been, and often, as Kelly noted, that person, especially with personality disorder, may come from a place of trauma themselves, and how can we care well and be part of that solution together. I'll maybe just because of time. Anything to add though, Kelly, before I move on there, just around stigma?
I think just like you said, right, just having the conversations, increasing awareness, right, just by continuing to have those conversations and having opportunities for education. I know I've done a lot of education in the community in support of family members, and so I think it's just opportunities and conversations for sure. Thank you.
And the next question, what setting do you offer this presentation or training, and do you need to be invited from the long-term care residents, senior admin? So this package was really that is available online are for educators to use, and all long-term care homes across Ontario are supported by educators. You might have heard the acronym PRC, or Psychogeriatric Resource Consultants. Kelly is one of them, and usually every home has a PRC attached to their home that helps come in and provide education. And most of them are part of our community of practice and should know about these resources, and they themselves could do the training. So it doesn't need to be Kelly or myself, although if it's a long-term care in Kelly's area, she would be a great person to come. But you can definitely ask the leadership of the home to know if that's something your home needs. We have recommended to our educators not just to go in and do this education without the need for it, because if nobody lives there in the home that has personality disorder, we don't want to confuse people with new strategies that they wouldn't be needing for those individuals. But if there is a resident living there with personality disorder, that would be the best time if that team needs to reach out to that educator, or it could be a BSO member themselves that could provide the education too, using the package. So yeah, I would say reach out if there's a need in your long-term care home, reach out to the educators. I do have a slide at the end with our email address at the Provincial Coordinating Office. So if that doesn't work and you still need some help, let me know and I can help find the right person for your home.
And I think the only thing I wanted to add in terms of the invitation piece is I do know with family councils in long-term care homes, it's up to the family council to invite, either leadership or somebody to provide the education. So because they're very much autonomous. And so, yeah, the invite has to come from family council. So just wanted to add that piece.
If it's to the family councils, yes, that's right. If the education was there. If it was for staff, I was speaking to staff education. So yeah, thank you, Kelly, for that. The next one, do you have recommendations for those who may be in denial about seeing personality changes in their loved one, especially for proactive intervention or support's sake? So certainly I think there can be personality changes or changes in behavior or how somebody acts with dementia. So we also don't want to assume that those changes might be personality disorder as well. But if they are personality disorder, those are kind of two different things, and you might need some help with a specialist, a geriatric psychiatrist, for example, to find that out and to see what the right diagnosis is. That's not answering your question though about how you might help with somebody who's in denial. But Kelly, I don't know if you want to speak to this or.
Sure. So in terms of a personality disorder, it is quite challenging because the person themselves quite often doesn't see themselves as having a mental health condition. And what's interesting is that's why we're finding people coming into long-term care without a diagnosis of a personality disorder per se, because the person didn't seek medical attention or didn't have access to a physician or a psychiatrist in the community. And so in order to gather that information and really establish those lifelong patterns of the behavior that we discussed in the presentation is really, really difficult. And so I think the key piece in all this is a person with a personality disorder, it is a lifelong pattern of behavior, coping mechanisms, that, at one time, serve their purpose and serve the purpose in sort of getting through some very, very traumatic life events, but would not be seen as socially acceptable or part of the social norm, if you will, from sort of everybody else's perspective. So yeah, it is quite common for the individual not to have that insight. And so that's where, kind of recognizing some of those characteristics, in the absence of a dementia, and then really working as a team to establish, healthy interactions and healthy boundaries for the individuals is really what becomes key. And that's what is evidence-based and research-based as an effective strategy.
And Kelly, do you want to, it ties in about if it's treatable?
Okay, yes. So In terms of medications to treat a personality disorder, they don't exist. The best effective strategy to use are those healthy boundaries, right? As we discussed. Having said that, though, it isn't uncommon for a person living with a personality disorder to also be living with a depression and or anxiety. And so certainly we would want to treat those things because those diagnoses do include intense suffering, right? So definitely we would want to treat a depression and or anxiety. But in terms of a treatment or medication, no, there isn't. It really boils down to setting the healthy boundaries, being consistent, and modeling, positive role models and healthy interactions, because that's what the person didn't have throughout their life, right? And so we're trying to build trust. We're trying to really help the person or support the person in learning what they can anticipate from us as a care provider.
Thanks, Kelly. The one thing I'll add to the treatable is that there is some evidence around cognitive behavioral therapy with personality disorder. But I would also say those services are rare to find as well. And so we're not seeing those services necessarily presented to that person as an option. But certainly there's evidence around that. And then I know we're almost at time, but I'm going to take that last comment about a person with past trauma living with dementia may require a safe support. So this info can be transferable. And yeah, there's certainly parts of it that can be. And I think that the person that wrote that is probably really cueing into the person-centeredness that we're really trying to show here around the person. And that means getting to know them, their personhood, getting to know who they are and what's important to them and their likes and their dislikes. The other part that's quite transferable is the validation that Kelly spoke of as well. When someone is upset, just to validate them and try to find out what it is that their needs are. So we did say that there are specialized skills. Obviously, the things like setting boundaries and such, we wouldn't want to use with someone with dementia, but there are some of those transferable of that personhood, person-centeredness, and validation that I would agree upon are transferable.
Thank you so much, Debbie and Kelly, for this wonderful presentation. So yes, we are wrapping up with our time. We've had amazing questions. If anybody has any additional questions, you're more than welcome to connect with me or with Debbie and Kelly for any follow-up questions. And as I had mentioned, this webinar has been recorded and it will be available on our YouTube channel, so you can view it again or share it with anybody who would be interested. Here we go. There we have the information if you would like to connect with Debbie and Kelly. And Yoan has put our information in the chat so you can connect with us. But yes, thank you so much, Debbie and Kelly, for taking time today to present this wonderful webinar. I think we've all learned so much, and that is the whole point of this Innovation Summit that Family Councils Ontario organize every year. We have our next event, which is tomorrow at 12 p.m. It is called Meaningful Design for Memory Care, How Wallpaper Murals Bring Comfort and Calm to Dementia Spaces, co-hosted by About Murals. So you are, everybody here, welcome to join us tomorrow again for the session. Your registration link gives you access to the full week of programming, so we will be very happy to see you again. So thank you so much, everybody, once again for being here and for being so engaging. And we look forward to seeing you at our next event. Thank you, everyone, and have a good day.